Hey, good evening, everybody. My name is Dave Taylor with Reichert. I want to welcome you to our discussion tonight, the glaucoma vital signs you may be missing, corneal hysteresis and IOPcc. We've got a great presentation for you this evening, and it's going to be moderated by Ike Ahmed. Just a few housekeeping notes before we get started here. Here's the agenda. Ike's going to take over here in just a moment and talk about why we're here today, what we're going to talk about. Then I'll come back on for a couple of seconds and just do a brief overview of a measurement we're going to be talking a lot about, corneal hysteresis, and how the device that makes that measurement works. And then the panel discussion. There's going to be some great case presentations and then some discussion about the evidence in the literature for these measurements we're going to be talking about today. And then Q&A. You can ask a question anytime. We ask that you type in your questions on the GoToMeeting control panel, and the moderator will direct the question to the appropriate panelist. Over on the right side of your screen in your control panel, there's some handouts that you can download, a couple of PDF files that hopefully you'll find interesting and useful. And after the webinar, you'll receive an email that will contain a link to fill out a survey. It's a very brief couple question survey that will help us improve next time. So we hope that you will just take a moment to do that. So at this time, I think I'm going to introduce you to our moderator this evening. Ike Ahmed really needs no introduction. He's world-renowned for his surgical skill and groundbreaking work in diagnosis and surgical treatment of complex glaucoma and cataract cases. He's published over 150 papers. He's a consummate educator. You always see Ike on the podium or these days on the webinar. He's an assistant professor at the University of Toronto and a clinical professor at University of Utah, and the director of Advanced Anterior Segment Surgery Fellowship at University of Toronto, and also the medical director of the Prism Eye Institute, where he practices. Ike, how about you tell us what we're doing here tonight?
Thanks, Dave. I just wanted to let you know that I appreciate your slides. I see a picture of your camping trip.
On the slide well, I'm sharing the wrong screen. Beautiful. It is nice, though, isn't it?
It is very nice. Makes me want to go outside, you know, the minus 10-degree weather we have here in Toronto sometimes.
Well,
but thanks for getting us going.
How about now?
There we go. So I want to welcome everybody. Thank you so much, Dave, for putting this together. You know, yesterday we had a program for our American colleagues, and it was excellent, great discussion. And for me, it was a great opportunity to learn from great speakers. And today, this is also going to be, I think, great. You know, just to put some backdrop on this, we're talking here primarily about making decisions in glaucoma, which I think anybody who practices glaucoma knows there's no simple decision to make. And we're informed, of course, by a variety of different parameters that help us to make the best choice for our patients and advise them. You know, very much like vital signs when we assess a patient coming into the ER, or when we assess a patient who's perhaps lost consciousness, or we assess a newborn baby, vital signs are so important to give us the status of what's happening and the prognosis of where we're going. We all, I think, agree that when it comes to IOP, OCT, visual field, these are all, of course, very important vital signs, but we're going to challenge things a little bit and say, do we need to go further on some of these parameters? Do we need to dig deeper, understand perhaps more on the biomechanical side of what's happening in the eye, as well as understanding a better assessment of IOP? And that's going to be the focus of this journey here for the next hour. Personally, I have to say I've you know, probably jumped on the bandwagon after many publications from Cynthia and Felipe Medeiros and others, who really, I think, showed the evidence when it came to the power of hysteresis when it comes to risk assessment and treatment decisions. Over the last couple of years, we've been employing hysteresis and IOPcc in our clinics for our glaucoma patients, and it's certainly been literally an eye-opening experience, and I really feel that it's become a very important part of our vital signs assessment when we assess our glaucoma patients. So I'm looking forward to a discussion today. Today we're going to have three speakers, plus Dave. Dave's a speaker too, but three clinician researchers as well. If you can get the next slide here. I'm very, very, very pleased to be here. I have to admit I'm a little bit intimidated when I am in this group here. We have Cynthia Roberts, who is really a consummate researcher when it comes to corneal biomechanics, when it comes to so much of the physical part of what we do, and really has a ton of knowledge. Every time I hear her, I have to take notes and go back and understand what she was saying, because it's so deep and so helpful. Gus Gazzard from Moorfields, who I think we all know, again, really top-notch researcher. I think when I have a picture of a professor, I think I have a picture of Gus in that dictionary here, because I think he really portrays a professor with not only his appearance, he's a good-looking guy, but also just in terms of, you know, the inquisitiveness and the thoughtfulness in his questions and the thoughtfulness in making decisions that are more evidence-based, as we've seen from some of the big trials. Marc Toeteberg is also one of our panelists from Switzerland who has touched lots of technologies. He is actually in the middle, literally, of doing an emergency case in the OR. We're hoping he'll join us. If not, we'll go over his slides as well, but we're very pleased that we have a nice international audience here. And I also see, looking at our attendee list, I see a wide variety of names. Some of them are familiar, and I've seen people from around the world, actually, including from North America, which are here today. So it's great to see you all. If I can go to the next slide, I'm going to actually get back to Dave here, because Dave, I call Dave the hysteresis nerd. I see that in a complimentary way, in an affectionate way, because Dave, who has been in this space for many years, although he looks pretty young, just really has wrapped his head around these concepts. And I can't think of anyone better to help us understand concepts like viscoelasticity, elasticity, hysteresis, and what they mean practically, and how we translate that to the eye. His pulse on the data, on the literature is fantastic. And so Dave here, you'll hear him speak, is really, I think, going to show and help us to understand what is hysteresis and how do you measure. So over to you, Dave. I think you're muted, Dave.
Probably better that way. Thank you for the kind introduction. I'm going to do 2 quick audience polls. This is the interactive part of the evening. You get to answer a couple questions, take a vote, see how it works out. The first question is, do you understand how to incorporate hysteresis into glaucoma decision making? That should be live on your screen right now, I believe. Let me just double check here. Launch, bam, you should see that now on your screen. And let's see, votes are coming in. It's about half and half saying yes and no, but the majority of the audience saying I need more information. Well, that's good. About 45% of people saying I want more information. That's why we are here tonight. So let me ask the next poll question. The next poll question is, do you feel that only Goldman IOP values should be used in glaucoma decision making? So you'll see that poll on your screen now, and you can vote. And we'll see how it compares to the results we got on our other webinar we did on this subject last night. Very similar, actually. 82% no. So it looks like over the past bunch of years, we've moved the needle on convincing people that maybe Goldman isn't the best tool in all cases. So let's close out that poll, and then you should see my slides again, and I'll go over hysteresis for a couple minutes. Now, I'm a car guy, so I compare everything to the way cars work. And what you're going to see here is a model car, and the wheels are rolling over a bumpy elliptical surface. And you'll notice the one on the right-hand side is flailing up and down uncontrollably, and that's because it's got a bad shock absorber. And so this is a way to introduce these concepts of elasticity, viscosity, and damping. People talk about springs a lot, and in the context of the eye, we talk about elasticity or resistance or stiffness, and those are all spring terms. But there's another component in the eye, because the eye is viscous in nature, also the tissues of the eye, and that's the damper effect. That's the shock absorber. And really what's going on here in this car model where the wheel can't maintain a smooth ride is the shock absorber is worn out. The shock absorber cannot stop that spring from oscillating as it hits the bumps going down the road. And that's damping, and that is of the realm of things that have viscosity. So when we talk about the eye, we talk about viscoelastic tissues. And when you think about the eye, it's very similar to rolling down the road in your car. There's a lot of stress and strain taking place. You've got intraocular pressure, you've got pressures surrounding the globe from ICP and venous pressure, and then you've got the ocular pulse hammering away on these structures of the eye 24/7. Somebody at one of the meetings years ago expressed it like this: the eye is under a constant assault. And I thought that was pretty true. And so the question is, can we measure the shock absorption capacity of the eye, and what does that shock absorption capacity tell us about ocular pathology, and in the context of tonight's discussion, glaucoma risk? So we're going to talk about hysteresis, and the term hysteresis is a term that is related to dissipation of energy. It characterizes the response to application and removal of force, always a load-unload phenomenon to make a hysteresis type measurement. It's not a new concept. The term's been around since 1890. It's not new in medicine either. If you go up on PubMed and type in the word hysteresis, you'll find over 13,000 medical publications that use the term hysteresis in them. Corneal hysteresis in particular is a term that we coined, and it reflects the cornea's ability to absorb and dissipate energy during the measurement process of the ocular response analyzer. It's patented and specific to that device. It was the world's first in vivo measurement of ocular biomechanics, and we like to boil it down to the phrase, how good of a shock absorber is the eye? So really, it's not stiffness, it's not elasticity, it's not resistance, it's this damping property of the corneal tissue. Dave Luce is the guy who developed the concept and laid the groundwork for all of the 800 plus publications that are now in the literature on this. Dave's not with us anymore, but I always like to remember him and thank him for all the wonderful things he's brought to the table in this area. Average hysteresis, it's measured in millimeters of mercury, is 10.5, and the standard deviation is about 1.5. I mentioned that because you're going to see some cases tonight with some numbers in them, and I just want you to have a frame of reference for what those numbers mean. It's a fairly stable metric diurnally and also with age, and this is how we make that measurement. Shine a beam of infrared light on the cornea, and we monitor the corneal curvature using that light system. There's an air pulse that impinges upon the cornea, and when the cornea becomes flat, we call that applanation, and we identify that by a signal peak. The cornea continues to become pushed upon by the air jet. It becomes indented, and as it comes back to its normal configuration, it therefore must pass through a second applanation. So you get an inward and an outward applanation during the course of one up and down air pulse measurement. This is what the signal looks like. That green curve there represents the rise and fall of the force function we place on the cornea, and the red curve is the optical signal that we receive from the light reflection off the cornea. The two peaks are related to the inward and the outward applanation of the cornea. And what happens is, because of this viscous damping, the cornea delays its motion, and you get a pressure measurement on the way in and a pressure measurement on the way out that are offset from one another. The inward applanation is always higher than the outward applanation. The cornea resists moving on the way in, and then it also resists moving to come back home on the way out. And the difference between those two pressure points is what we term corneal hysteresis, and it's a characterization of energy dissipation during that deformation. And so the average of those 2 points gives us our Goldman correlated IOP measurement. The difference between the two gives us corneal hysteresis. And we do something special with those 2 points as well. We have a special algorithm that gives us what we call corneal compensated IOP, basically a hysteresis adjusted pressure measurement that seems to be more closely related to the true intraocular pressure. It is a Goldman correlated pressure measurement, and that is to say it agrees with Goldman on average, but it is not affected by central corneal thickness and corneal biomechanics in the way that Goldman tonometry is. Changes less after refractive surgery than a Goldman measurement would. So when you look at an aura screen, these are the measurements that you see. The corneal compensated IOP that I just referenced there is on the top. The corneal hysteresis is in the middle, and then the Goldman equivalent, we'll call it the classic IOP value, is there as a reference so that you can tell perhaps you've been over or underestimating the pressure in this patient all along. Finally, we have something called a waveform score, which is kind of like a quality index or a signal strength indicator that tells you if it was a good measurement or maybe you should take another one. So with that, I'm going to turn it back over to Ike to take us through the rest of the evening.
Thanks so much, Dave. That was a great run through on hysteresis and what some of the outputs are on aura. I think there's going to be a lot of questions, and I want to encourage the audience. I see there's some questions coming in. You know, just type it away on that. You can ask whatever you want. Everything's game here tonight or today, depending where you are. So this is the breakdown here. We've got 4 topics we want to cover. We're going to use some cases to highlight some of these areas. We've switched the order a little bit. Hopefully Marc will be able to get here. If not, we'll be able to continue without him, and we'll cover each area that I think will be of interest. So with that in mind, I'm going to pass it over to Cynthia, who is in Ohio, the great state of Ohio, And we'll be speaking about understanding some of the parameters like IOPcc, how it's compared to GAT, how useful is it, how to make sense of these parameters. So thanks, Cynthia, for being here.
And I appreciate the invitation as well. You can go ahead and advance that, Dave, to show my disclosures, and then advance it again. So let me tell you, there are two main issues in glaucoma that I think are very important for every glaucoma specialist to know. And the first one is that refractive surgery, we know, started in the 90s. So anybody that's had refractive surgery in the 90s may be showing up in your clinic at this point in time at risk for glaucoma. But what this particular plot shows, and it is my favorite plot in the literature, because it shows 8,113 subjects retrospectively with refractive change on the x-axis and measured IOP change on the y-axis. Dave, if you hit that once more, we'll get some arrows. And if you look at -5 diopter correction for myopia, so every subject, every one of these 8,000 plus patients had a decrease in curvature and a decrease in central thickness. And you can see at a -5 diopter correction, the measured pressure varies from +10 to -12. 22 millimeters of mercury, all of whom had the same reduction in central corneal thickness. And if you look at that zero line, there are literally thousands of patients that had an increase in measured pressure. So it's really not important that the average difference was -2 millimeters, because everybody has in their head after refractive surgery, you need to subtract 2 millimeters of mercury from a Goldmann measurement. That is completely misguided. And if you look at the R-square on this, 0.009, it tells you that this change in thickness accounts for less than 1% of the variability in measured applanation tonometry. So what can possibly cause this problem? And if you look at the fundamental assumptions of Goldmann tonometry, of course, there's an assumption the cornea is infinitely thin. We know that's not true. But if it's relatively uniform, you know, there's many, many, many years of intuitive database that this relatively uniform thickness will produce a certain measurement. And what happens after refractive surgery is you've completely destroyed this pachymetry profile by taking the thinnest spot of the cornea and making it thinner. So it is impossible for Goldmann to accurately measure pressure after refractive surgery. And if you get a patient in your clinic, go backwards, Dave, it will not help you. Now, I showed this because I want you to notice the only pressure-bearing component of the cornea after LASIK is the residual stromal bed. So even if you fill in that hole with a flap, it doesn't carry any tension. So if IOP goes up, which is what glaucoma specialists are worried about, if IOP goes up, the bed carries and the flap doesn't. And in fact, the flap can fool a Goldmann tonometer, which just changes the surface shape minimally. And we'll see that in this next slide for the case that was sent to me. This is courtesy of William Wiley, and he shows a 57-year-old, 5-year post-LASIK female complaining of blurry vision and pain in the right eye, multiple office visits with a normal Goldmann pressure. But the ORA is 46 millimeters of mercury. Now, this is not just due to the LASIK. This is due, the LASIK can't provide, Goldmann can't accurately measure the LASIK, but what this is due to the fact that as pressure goes up, it's all held by the bed. And that floppy flap sitting on top, the Goldmann probe is going to get lost in it, and you will not get a good pressure measurement. So if you add edema and high pressure onto the LASIK, it makes it very much worse. You can go on. And the other problem is, and this is, we published in 2005, that actually the stiffness of the cornea determines the relationship between central corneal thickness and measurement error. If you have a stiff cornea, which is that top curve, you have a strong relationship between corneal thickness and theoretical prediction of IOP. But if you look at that bottom curve, that is a cornea, and I would say in glaucoma, that's been treated with prostaglandins, because it's well documented that prostaglandins will reduce the stiffness of the cornea. So with a cornea that's been treated with prostaglandins, there is likely no relationship between measurement error and central corneal thickness. So in my opinion, the two cases where Goldmann has the worst performance is after refractive surgery and in a glaucoma patient treated with prostaglandins. And I'm over the time Dave told me that I could speak, but I want to say one more thing about hysteresis. Oh, we're going to go ahead and go to the next one. So this one shows a patient who I would guess is on prostaglandins. I don't know because it was submitted by Nathan Radcliffe, but you have the correction. The difference between IOPG and IOPcc is IOPc is higher despite the fact that this is a thicker cornea, and you would think that that's Goldman would be overestimating the pressure. The correction is opposite. So this is likely a patient on prostaglandins, and that's why you have this disparity in what Goldman produces and what IOPcc produces. And so with that, I will say one more thing, and that is we have evidence right now that will come out very soon that the hysteresis is not only from the cornea, that even though the load is applied on the cornea, the entire eye dissipates the energy. So the connection between the cornea in the front of the eye and the damage in the back of the eye is the sclera, which actually helps dissipate the energy. And that's why you can predict glaucomatous progression with measurement of hysteresis. I'm done. Thank you.
Fantastic, Cynthia. I could listen to you all hour and look forward to your comments, and we'll bring Gus in as well. It's interesting you mentioned that, Cynthia, because when it comes to corneal biomechanics, I think all of us have kind of, sensitized to this concept of corneal thickness and its relationship in OATS and everything else. And we know that, there's likely some IOP measurement error, but there's also something else going on, right? There's something else going on as far as the corneal biomechanics that makes certain patients at risk for progression versus others. And your comment about the cornea representative, or at least the hysteresis measurements representative of the ocular overall hysteresis, is an interesting point, and perhaps explain some of the relationship to risk that we'll be speaking about shortly. And it's important to distinguish that as well. Now, there's been some questions coming in, and again, we want to make this as interactive as possible. I have a number of questions that have come in, so I'm going to let both you and Gus answer them as well. This is a basic question. I appreciate the questions here. The main issue in non-contact tonometry is it overestimates higher IOP. Okay, this raises IOP. So how is this different or handled with aura? So we often get this question about, the historical context of NCT, non-contact tonometry, and we know a thicker cornea, we often get higher IOPs. So how is this different? How is aura different than if it's basically still using air puff?
Can I answer that? Okay.
Yeah, I think you should.
The case that I just showed is the case in point of why that doesn't work. You had a case with a very thick cornea, and what this tells you is that was not an overestimation. And I have a longer presentation on IOP measurement error, but Dave wouldn't let me use it. And the problem is central corneal thickness is only a predictor of measurement error in a stiff eye. If you have a soft eye, like an eye that's been treated with prostaglandins, how many glaucoma specialists use prostaglandins? Goldman tonometry will not work. And you will have a thick cornea that's been treated with prostaglandins, that there's no relationship between corneal thickness and measurement error. So the assumption that a thick cornea overestimates pressure is fundamentally wrong.
And I don't know, Dave, I think you're muted, but I know you probably had a comment on just the traditional 40-year-old NCT versus this.
And it's actually true, and we knew this years ago, that the NCT measurement was more affected by these corneal properties. If you do a plot of IOP versus corneal thickness in Goldman, and then you do that on an old NCT, you'll get a higher R-square, a steeper slope with the NCT versus corneal thickness. That's actually why we can measure corneal hysteresis. And if you think back to that graph I presented with the in and the out applanation, if the old NCT, including all the competitive devices on the market today that use air puff technology, are only looking at the inward applanation. And just like a Goldman tonometer, when you look at one number, you can't determine two things, pressure and corneal contribution. So that traditional NCT measurement has all of the problems Goldman has, plus a component of what we call dynamic resistance. Because we're moving the cornea rapidly, it's resisting the deformation even more than a Goldman would. But the aura, because it's bidirectional and it's looking at the in and the out applanation of the cornea, is quantifying that corneal effect and removing it from the equation.
So I've got a question for Cynthia and maybe Dave, which is that if corneal thickness is such a difficult entity to correct for because of the variability of its influence on the pressure measurement. Should we be completely replacing it with a stiffness hysteresis measure, or do you think it still has a role to help us interpret this set of data?
Oh, I'm not a clinician, but I think that the way the glaucoma specialists use it is appropriate in that you look at thin, medium, and thick corneas to look at risk. I don't think there's a single correction formula out there that will accurately correct IOP measurements. And in fact, you have a slew of correction formulas from which you can choose, all of which are different. So which one do you choose? And the question that I ask in looking at them is, you know, if central corneal thickness were a fundamental source of error, they would all be similar. So I think the way the glaucoma specialists use corneal thickness in looking at glaucoma risk is because certainly a thin cornea also is a more compliant cornea and likely corresponds to a low hysteresis. And you might have a problem in that case, so that you have low damping of the sclera and cornea in terms of being able to dampen all of this pressure fluctuation. So I think CCT is okay if you use it generally, but if you try and use it to correct IOP, it's a mistake.
Yeah, I'd certainly echo that. I mean, I'm constantly asking people, in residents, and trying to get residents not to perform some kind of arbitrary correction factor that they've learned on the way through, and sometimes to pick up from somewhere else when they come to us. And they need a little bit of re-education, shall we say? But I think it's fascinating because we think in a sort of with a single metric. We think about a single pressure metric. It's nice and simple. We think we've got it sorted. We then come along and realize that it's not the whole story. There's measurement error, corneal thickness, and actually what we've got is almost a three-dimensional hysteresis stiffness damping property plus true intraocular pressure with a degree of corneal thickness thrown in there with some to prove some measurement error, which adds a degree of complexity that makes a simple clinician nervous at how we interpret that. So I think what's going to be really exciting over the next half an hour, maybe in the next few years, is working out where this fits into our risk algorithm when we adjust the risk algorithm for different ways of applying that particular set of risk factors.
I think as you apply that, I think you're going to have to separate your populations into prostaglandin treated and non-prostaglandin treated, because you'll get a different answer.
Just want to continue on with some of the questions here, and again, this can be for Gus or for Cynthia. Can you discuss, the IOPG and IOPcc, and you see both values? How do you look at those values when you do this for patients?
If I could make a comment on IOPG, because that case that I showed, it gave an IOPG reading. If you would have used actual Goldmann, I mean, the reason that fools Goldmann is because it's just a probe that has a very small indentation, whereas IOPG inverts the cornea. So the flap can't fool IOPG. So even though there's a correlation in a normal population, doesn't mean there's a correlation in a pathologic population. Goldmann would not have been able to measure that appropriately. So I think, all devices that measure IOP correlate, because the only thing correlation means is if pressure's up, it's higher, and if pressure's low, it's lower. Whether they agree is actually a completely different question than whether they correlate. And I guess that's my bias. So that IOPG is probably a better estimate of an applanation pressure than Goldmann, because it's not, at least in refractive surgery, it won't be fooled by a flap.
I want to get back to a little bit of basics. And I think we probably should cover this because questions come up like, what is IOPcc? What is that? What does it mean? So that's corneal compensated IOP. What exactly is that when you see a reading of IOPcc? Maybe you can just answer that basic question, because many of our audience members, of course, are very new to the technology, of course.
I don't know, Dave, do you want me to do that, or do you want to do it?
Yeah, I can answer that very, very quickly. It stands for Corneal Compensated IOP, IOPcc, and the CC stands for Corneal Compensated. And we did that because it's different from the traditional, even the traditional NCT measurement of IOP. So we wanted to give it its own distinct name so that when you reference an IOP, and people in the scientific literature should always report what tonometer they're using to make the measurements, because they're all affected by things in different ways. So we wanted to make sure that when people talk about the measurement made by this device, they're talking about IOPcc.
And it's more than which tonometer, which parameter in that tonometer, because there are plenty of papers in the literature that said they use the Ocular Response Analyzer and then they don't tell you whether they used IOPcc or IOPg.
There's a question here about confounders. IOP is one, for example. So would a higher IOP, how would a higher IOP change hysteresis compared to a lower IOP? Someone, for example, who has medical treated glaucoma, they had a pressure of 30, now their pressure is 15. And how does hysteresis change with IOP in the eye?
I can answer that if you want, Dave. As IOP increases, the cornea's ability to dissipate energy is reduced. It's fundamental. So hysteresis will go down as IOP goes up. And if you think of hysteresis as a way that the eye dissipates energy, then it makes sense. So as IOP goes up, ability to dissipate energy goes down, so hysteresis goes down.
Great.
So that's one of the ways in which I think we've got some complexity here that makes requires some careful thought and careful processing about how we build this into our risk models, because every time we sit in front of a patient, we essentially create a specific risk profile for that individual, and that's risk of retinal ganglion cell loss, risk of vision loss, risk of visual field deterioration overall, and also at that particular time. And we take the pressure there and then amongst everything else that we factor into that, in family history and everything else. But the pressure measurement is a metric at that one time, and corneal hysteresis changes with wide differences in pressure for a given individual, which is what you're just stating. So yes. Therefore, our risk profile is being built on, and if we incorporate this extra metric of corneal hysteresis, we have to be careful about when we're measuring it and in what circumstances we're taking that measure. We need to repeat that measure again and look and see how it's changed.
Yes, you do, because
that's not what everybody gets. I mean, I think that's a really fundamental characteristic of corneal hysteresis. Some people think that this damping profile, this damping property, is a given property of a particular eye or a particular body, like height or some other fixed property of their body, whereas actually it's a much more dynamic characteristic of eye behavior in the context of stress and strain.
Absolutely, and anybody that thinks hysteresis is a characteristic of an eye, that's a huge misconception. It changes with IOP because it does change. The damping ability of the eye changes with IOP, and it's probably one of the reasons that high pressure is a problem, because the ability to dissipate energy is dramatically reduced. So it's very complicated in terms of the biomechanics, and you cannot assume, it's not CCT, which is relatively constant, it's not curvature, which is relatively constant. It's a biomechanical parameter which changes with the eye's ability to dissipate energy. So you can interpret it in glaucoma. You can interpret the ability of the eye to dampen by that hysteresis value. So if you have
we can get pretty
low IOP, it's a problem.
Yeah, I mean, we can get pretty deep on this, and I think those are really good points. We have to always consider that when we look at studies, for example, and understand the interplay between IOP and hysteresis when we look at risk assessment. And I think when we talk about that, but let's move on. A lot of great questions coming in. We'll try to get to as many as we can as the program continues along here. I'm gonna have Gus present his case and discuss a bit about some clinical scenarios and treatment planning. So Gus, thank you.
Yeah, hi. When Dave asked me to speak and asked if I could dig out a couple of cases that might speak to this area of interest, I thought I would go just down and dirty and grab a couple of very real world cases from a clinic. And next. And I do have funding acknowledgements. I'm primarily funded by the National Research in the UK to fund laser trial, amongst other things. Next, thanks. But so what I've got is I've got two simple cases, both of which are individuals who lost vision, and it's less about the decision making and what decision we made, is more about when we made that decision and how long did we have to wait to take that decision. So this was a lady who was, been monitored without treatment for 5 years. She'd been given a diagnosis of low pressure primary open with pressures measuring with very thin central corneas in the low to mid-teens on Goldman, and she'd been phased and had a number of different risk factors: low systemic blood pressure, migraine, Raynaud. She pretty much ticked every box for the classic NTG, low pressure primary open angle glaucoma patient. She was a low myope, not particularly myopic. She'd not had any LASIK, but her corneas were 455, 447 microns, and so classically we'd be worrying about that level of thin central cornea giving us some degree of measurement error. And she'd been treated, as everyone is, Cynthia, with a prostaglandin amongst other things. And she then started to show really confirmed progression. So she was treated without pressures initially because she was very hesitant to be treated at all. She was monitored without any medication. Somewhere else was just keeping an eye on things, and maybe for that period we might have had a different risk assessment for her if we'd ever been able to, at that point, build in some extra metric that had helped us identify that she was at greater risk. And of course, we all know that with visual field, with a period of monitoring, and this was her initial monitoring was really pre-OCT, certainly nothing that was going to be very useful. And for that period, it was difficult for her, what essentially was a pre-parametric glaucoma, and it was difficult for her to take that step of accepting treatment and moving on, saying, okay, fine, I will initiate treatment at the very beginning, and then by the time she came to me, initiate surgical treatment. So some rough and ready visual fields. By the time that she came to me, she was already losing central vision in 2014, and that progressed quite rapidly in the one eye. The other eye too, a little less worrying because it was not quite such central visual loss, more of a nasal step. If we back up a couple of slides there, Dave, just go back there. And with those two, back up, sorry, one. And she had been treated medically, probably in my book, I think too late, later than I might quite like to have done, but we had to take that step with her and advise her accordingly. And her original ophthalmologist had felt, well, you're pre-parametric, you've got normal pressures, you may just have funny looking discs and we can do nothing. She then went on to have confirmed progression, but again, taking her from that step of accepting medical to moving on to surgical treatment, with all the risks that come from a single digit surgical target, that was hard for her to do. And it was only really at that point that she then, post-surgery, had access to corneal hysteresis measurement, and she had very low corneal hysteresis, having already had trabeculectomies in both eyes. And I just included her with the trabeculectomies and the surgical story that she had. She had mitomycin C augmented trabeculectomies 2014 and 2017, but she then went on to have a revision for above target pressure in her left eye, and then that overshot, and she ended up needing to have a little bit of an adjustment because she had below target pressure with sequelae of some hypotenuse maculopathy and choroidal folds, and she had a transconjunctival oversow, and she settled out pretty nicely at pressures in single digits and excellent best corrected visual acuity, and we have stabilized her progressive glaucomatous deterioration. But it comes with significant work, and with that significant surgical work comes significant risk. So when we're making these decisions, and we're holding our patient by the hand and taking them through this process of accepting risk, and Dave, you can flick through now to the OCTs, just showing that there are worse signs of change, and next, and then hopefully things stabilizing, and then move on to the right the way through slide. So so that lady really, she had progressive glaucoma. We could make the decisions to give her treatment. We could make the decisions to give her surgical treatment at those times. But both of that ended up with her suffering visual loss and central vision loss in one eye, either before the surgeon was willing to intervene with her first clinician, or before she was willing to accept surgery because of the risks attached. And I just like to think that maybe if we can build in an additional risk factor into our risk profiling, we'll be able to take those steps appropriately, safely, perhaps earlier. So this is another lady, also grabbed from clinic. She was diagnosed again elsewhere, 2011. She self-referred much more recently for a second opinion because she knew she was getting worse. She'd had visual field deterioration on a single drug. She'd been treated with Lumagan alone, with pressures reported around about 17, close to her maximum pressure, over a period of about 9 years. So she'd been, you know, it was one of those sad, perhaps slightly undertreated stories where somebody, despite medical treatment, was progressing, they were getting worse. And on our first meeting, she had a Goldman pressure of 16, she had an IOPcc of 20, and a corneal hysteresis of 6.7. So that's more than 2 standard deviations from Dave's mean that he was reporting for the population-based mean earlier. And her visual acuity in that eye had already dropped because of severe glaucoma. She had very thin central corneas and she had an afferent. So she came to me seeking an answer, and I do what I often do when I think somebody really needs surgery, is tell them they really need surgery, but give them some drops while they go away and think about it, so they can get used to me and get used to the idea of what they needed. And her Goldman was 10, but she was both subjectively very rapidly and objectively deteriorating much more rapidly than she had been previously, and she accepted her mitomycin C augmented trabeculectomy with Avastin, and has now got a single-digit controlled intraocular pressure, and she is subjectively stable. But if Dave, you flick in, this is her good eye. So in the right eye, June of last year, she's still doing not too bad. You can see some beginning signs of some early field loss. Her disc's not doing too badly in the right eye, but she's clearly outside the normal range in some areas. Flick on, Dave. And the next, some retinal nerve folio, clearly, and then looking in signs of sort of deviation of a ganglion cell layer in that right eye. She's clearly getting some significant change before those visual fields are really doing very much. So we've now got the benefit of early signs of change detection with our OCTs before the visual fields are really starting to change. That's the difference between these patients and previously. We would like to be intervening at an earlier stage, and I think being able to assess the risk of that is helped if we can build into this an additional risk profile. Okay, Dave. So catastrophic rapid. Okay, thank you. And the next, catastrophic rapid visual field loss that's occurred prior to her having surgery, which I think, because her field was just about hanging on. And next, sadly, could quite possibly have been prevented had we been able to say, look, this patient with pretty good fields really needs more than this. And next, please. And it may be that with, thank you, next. And next. And maybe it was that if we'd built in this extra metric of corneal, of ocular damping, of corneal damping, of shock absorption, this idea that maybe we could have identified with something much simpler than a whole series of OCTs, which aren't, let's be frank, available to everybody out there. We can't necessarily be doing spectralis OCTs 4 monthly for all of our patients, even in the best of clinics. Be identifying and pulling out some sense of risk that would be an early identifier of patients who are in need. And I think, you know, her gap was as underestimating a real pressure. The resistance of both of those patients were resistant to initial medical treatment and certainly very resistant to definitive surgery. The second lady had quite significant refractive error. And I think the aura helped in the second decision to operate by we knew she needed surgery, but it helped us really show that she needed something, had some additional factor risk that hadn't been seen previously, so she could understand what was happening, what was going on. And I think it could have helped us avoid, not just make the decision now, but helped us avoid making the decisions quite so late on in the disease process. Could we have picked up and identified that at-risk person before we actually needed to wait for such field deterioration as they had before they actually got the surgery that they needed? So that's my sort of 2 case tuppence worth of input to where I think we should be going with profiling our patients, including some measure of hysteresis or shock absorption or corneal damping. I'm fascinated about where it's going to be in that risk profiling in a year or 5, because I think there's still a lot of questions to answer. What I think we need to be doing is gathering some of that data for both patients and studies so that we can answer the questions of how we implement it. Right,
Thanks so much, Gus. Thanks so much, Gus. Those are pretty great dramatic examples, and again, thinking of glaucoma as a puzzle, this kind of helps us toward build that case for moving more aggressively or not. Yeah. Interestingly enough, Paul Singh yesterday presented a case where a patient was on medical therapy for years and had a hysteresis value of 11.7, and the patient was stable, and basically used that as a justification to actually stop the medication because he was felt that this patient had a low risk for progression. So whether it's being more aggressive or sometimes even being less aggressive, getting more information about the true IOP, but also hysteresis as an independent risk factor can provide some value. Dave, I'm wondering, before we get to some questions, if we can get to Philippe Medeiros' slide. This is part of Marc's talk, and I know we can't really get to Marc's talk, but I thought that, for me, one of the clinchers in understanding the importance of hysteresis as a risk factor for progression was the DIG study. This was a very well-designed prospective longitudinal study that Philippe Medeiros was the PI for. I basically followed patients, about 100+ patients over 6+ years, and measured everything: OCT, IOP, visual fields, different risk factors, and looked at a variety of different risk factors for progression. And I think quite conclusively showed that hysteresis had a very strong predictor for progression. Those eyes that had a high hysteresis, even if the IOP was higher, didn't progress, and certainly didn't progress very fast, compared to those eyes that had a low hysteresis, even though those eyes with low hysteresis had potentially lower IOP. And so that graph on the left kind of just shows individual lines per patient. You can see the difference between both groups. And so he developed a table you see on the right, which is basically looking at percent loss per year. And on the y-axis is IOP, on the x-axis is hysteresis. And you can see that a patient, for example, who has a high IOP, let's say 25, has a hysteresis of 11, that risk of visual field loss based on the DIG study was fairly low compared to a patient who had maybe a IOP of 15, but had a lower hysteresis. And so these are some interesting findings that I think help us to understand the interplay between hysteresis and IOP, and again, whether it's a matter of underestimation of IOP or whether it's a matter of the difficulty or the challenge for the eye to handle the IOP, the dampening effect, or both. The ability to incorporate this into clinical decision making, I think, is what's exciting here. So maybe we'll go back to our talking heads, Dave, and we can all contribute. I'm going to get Cynthia to make some comments on Gus's presentation on this slide.
Can you put that slide back up? Because I think that illustrates it. When I watched that case, the biggest red flag to me was the extremely low CH with a normal IOP. If you have a high IOP and a low CH, that's the way it's supposed to be. If the pressure goes up in a particular patient, hysteresis is going to go down. But you have somebody there with a low IOP and low hysteresis. So even with a normal IOP, the damping ability is very low, and you can see it in that graph that Ike just pointed out, low hysteresis and normal pressure is a huge red flag. And if you have high IOP, those people with high IOP weren't left with high IOP. When their IOP is brought down, their hysteresis is also going to come down, but that's the way it should happen biomechanically. You should not start out with low IOP and low hysteresis. So that combination, and I would say that you should always look at the IOP at the same time you look at the hysteresis, because the combination of the two is what is the big red flag.
Great, thank you for adding that, Cynthia. There are a lot of practical questions that have come up, and I'm just going to throw it out for both of you to kind of help answer. When you do measure IOPcc and hysteresis, is there still a need to measure Goldman based on what we've heard?
In my opinion, no.
Well, I knew what you were going to say, so I was going to dive in first, but missed it. I can tell you what I'm doing, and I can tell you what we're doing at Moorfields. And I'm not sure that there is yet a definitive answer there, because there's a very wide range of opinion and practice. And when there's a wide range of practice, I think it shows you that there isn't the definitive answer. It's like there are a lot of MIGS procedures out there because we haven't got the single best MIGS for all time. And the same thing I think applies to practice here. I have some colleagues at Moorfields, academic colleagues at Moorfields, I won't name and shame, but who are only using Aura in their private practice. They have pretty much abandoned using Goldman. They think they are using Aura with corneal hysteresis. And I have other academically minded colleagues who are doing the opposite. They're still stuck with a Goldman because they've used that Goldman for so long. It's a safety blanket. They just can't let it go. It's got a single number. It's nice and easy, and it's part of their routine. Maybe I'm being unkind. What we're actually doing as a service, and because I'm the service director, we've had some big changes with COVID, and what we've done is we're pushing about half of our patients through virtual clinics with our data collection clinics, imaging fields, pressure, and a short questionnaire. Those patients are all getting just Aura. They're not getting Goldman. Goldman's a random number generator if you put it in the hands of a technician who's been trained for 10 minutes. It's worse than that. It gives you a false sense of security. Whereas, so we abandoned that for some very, very pragmatic reasons. The data that's coming out showing that the Aura-derived IOPs were better predictors of visual field loss in longitudinal trial studies from Ted Garway Heath and others than were Goldman's. That really made sit up and take notice, because I first looked at Aura way back when in Singapore. And we've made the shift to doing that. We're going to look at that carefully. We're going to audit how that does. But I think in my personal practice, I do Aura on every single patient, and I do Goldman on a subset of those. But I think we'll be probably moving towards an Aura-only predominant practice for the majority soon.
Which ones do you do Goldman on? Gus, which ones, you say you do Goldman on a subset. Which ones do you do Goldman? Which patient characteristics would lead you to Goldman?
The patients who ask, or when I have a surprise.
A surprise.
A difference from what I'm predicting or expecting. If there's a number there that I'm sure about. If there's a number there that wasn't heading the way I was expecting to heading. There's a degree of pragmatism based in that sort of practice rather than science. But if somebody's post-op or they've been stable for a long time and the numbers are off or very odd, then I'll often repeat it.
Yeah, and I think those that come in, they've had a Goldman done before, right? Just kind of as a bit of a reference from a referring doctor or from your group. So I think that's and also historically, if I've got historic Goldman data on somebody for twice yearly visits for 5 years, then in terms of sort of continuity of measurement, I think it's important to do that. I agree. Practical question here. How do patients, tolerate the puff? Is there any issue with tolerability or difficult eyes to get Aura done?
I've had it done many times myself as part of studies, and it's the softest air puff, not a problem at all.
There are some people who don't like it, but then there are a lot of people who don't like Goldman. So I think it's probably better tolerated than Goldman.
Questions come up about hysteresis. You know, you've spoken about the value in diagnostically speaking. What about monitoring patients? Is there value in using it hysteresis over time, repeating it and monitoring somebody, or is there value really more kind of at your initial diagnosis to kind of set your risk level?
I repeat it and I look at it again because of what Cynthia said earlier about the actual corneal hysteresis changing with IOP. So when I first started measuring it, I got it wrong. I thought it was like corneal thickness and axial length. I thought it was pretty much fixed. And when I realized it was a bit more complicated than that and it needed to be viewed in the context of other metrics, I realized I had to repeat it to see what it was. Not to look for a trend, but to see what the risk assessment profile with hysteresis was at that particular level at that particular time. If pressure's not changing wildly, I don't necessarily take much notice of day-to-day, week-to-week, month-to-month measurements. But if I got a big swing in intraocular pressure, I re-baseline and use that as a risk assessment. But at the moment, I still don't know how much weight to put on it. I've told Dave this. I'm not sure what the relative weighting of these different metrics should be. I think it's fascinating to look at it and very interesting, and I think it's going to become important. But I want to get it out there in some big longitudinal studies so that we can really start to measure the contribution of that risk metric in our risk profiling, just as we know that for the diagnosis or progression of glaucoma, we know that a myopic refraction is relevant, and there's probably a dose-response relationship based on some big epidemiological studies, Blue Mountains Eye Survey for one. We know that that's a significant risk factor for progression as well as diagnosis. How much do we weight that against family history? How much do we weight that against a low eye pressure, low corneal hysteresis? I don't know, but it's going to be exciting to find out.
And I would say anytime you measure, if you're using IOPcc, the hysteresis comes for free. So you might as well look at it if you use IOPcc, you've taken the measurement. But I would also advise never look at hysteresis in isolation, always look at it with IOPcc. How do they both change? And that will tell you what's going on much more than looking at either one in isolation.
And there's been questions about CCT. If I'm measuring CCT, is that enough? And I think you've answered those questions already. That doesn't really give you the story about the biomechanics. It just gives you a thickness value. And we have people who have thicker corneas who have, low hysteresis and vice versa. And I think it's more important to look at the dynamic of hysteresis in that population as well. A lot of questions. I know we just have really just a couple of minutes here. Questions around how the strength of hysteresis compared to IOP or CCT or OCT. And I mean, Gus, you touched on this as well. Of course, we don't have the real answer. How much does what contribute to risk factors? But relatively speaking, from what you've seen in the data, how much do you think hysteresis contributes toward the risk factor for a patient progressing versus, let's say, CCT or IOP alone, or even an OCT value? Any thoughts on that? I know it's a tough question, but you like tough questions.
Question because they're linked metrics, so you can't, because of what Cynthia's just said about pressure and hysteresis. I think practically speaking, I'm putting patients into theoretical bins of high, average, and low, just as I do with corneal thickness. And there's the crazy outlier with the 400 micron cornea where you go, wow, they're really thin. But I'm looking at hysteresis in those sort of broad groups. Now, what are the cutoffs for those groups? Are those cutoffs the weighting of those risk profilings correct? Is that doubling your risk or multiplying your risk by a factor of 10? I don't know. But I think it's helping me with some of my difficult decisions. We've all got those patients where we have a decision where we think, I kind of think we should do this, but I'm not sure. And it will perhaps stay my hand if they've got a high corneal hysteresis and I've got poor evidence of progression or deterioration, or perhaps it will it will strengthen my nerve if I think they really need something surgical. If I see that they've got a very low corneal hysteresis, that a low normal pressure, and I will say, well, look, well, maybe, you know, there could be a contribution from that, whether that's measurement error or a fundamental damping risk, a risk from a loss of damping. I think we'll have to talk about that another time, but that's going to be one of the interesting questions that we've got for the next 5 years.
Yeah, and I think that I like exactly what you do. I like to group them whether they're, you know, high, average, or low hysteresis values, and it gives me a risk factor analysis. It's quite interesting. I've got a series of eyes where there's very asymmetric glaucoma. The one eye has a lot worse than the other eye, and interestingly enough, the IOPs are not that different, but the hysteresis is far lower in the more damaged eye than in the eye with less damage. Now, there are other factors as well, of course, and we can debate that, but that is an interesting finding that I do often see when I look at asymmetrical disease independent of IOP. But as you said, they are linked in many ways, and it makes it hard to deduce one from the other. That's why I like Felipe's graph. It kind of, you know, plots out IOP and hysteresis together, yeah, and not looks at each in isolation. So I think that's really great. There's been a bunch of questions about, and I know we're just running a bit over, maybe one or 2 minutes, because they're practical questions.
Fine by me.
About false results with air puff, like squeezing of the eye and things. I'll just answer that one quickly. I mean, with a Goldmann, you can get false results with patient squeezing and inaccurate positioning and things like that, or Valsalva. So any of these measurements could potentially be impacted by that. I would think actually with how fast this test is done, if anything, perhaps there may be less artifact from patient squeezing or moving or other things like that. But of course, that certainly can in some cases cause some artifact. We have to remember what we're comparing to.
Yeah.
Yeah. Go ahead.
No, I was going to say one of the big things that made me sit up and take notice about careful questions about how we're going to measure pressure in these virtual clinics was revisiting some of Architecture's work, looking at the retest reliability of Goldmann in the first place. We love Goldmann because we're used to it. We love Goldmann because it gives us a single number and nobody can tell us we're wrong. But you know what? It's actually a pretty shockingly poorly reproducible instrument, and that, you know, the 95% limits of confidence limits of measurement are pretty horrendous. A lot of those patients are going to be a long way away from what their true pressures are simply through measurement error and random noise.
Well said. And I take it, obviously, and there's one last question here, just in the era of COVID, any concerns about aerosolization with the air puff? Obviously you're using it, Gus, but, or Cynthia, any comments on that if that comes up?
Yeah, we just completed a study that we're going to submit later today, where we used a high-speed camera, and one of the devices we used was the ORA, and if you don't add tears, there's no drop formation at all. And we looked at the hydrodynamics of the tears move away from that central concavity and hit the lids, and unless there is an additional tear load, nothing comes out. And we have the video evidence to demonstrate it. So we'll be submitting that later today.
That's great. And many of us have continued to use Aura based on your work and others as well. You know, I think we're all comfortable with that. Dave, maybe you want to go to the closing slide. I know that that we are kind of at the end of our time, and I just want to just briefly I'm going to actually ask both Gus and Cynthia to maybe give some closing comments, just what you really want the audience to remember. Specifically, this kind of summarizes a bit, but maybe I'll go to Gus first. Just, you know, any parting words about, you know, giving the audience some thought about, you know, thinking beyond just IOP and thinking about biomechanics and how we incorporate this.
I think if you're designing a study, please incorporate corneal hysteresis so we can understand it better. But I would say that I'm an academic. The clinician in me in the day-to-day, he's running my 4 clinics and looking after 70,000 patients here at Moorfield, would say that I think it's going to be becoming increasingly important, and we're going to look very carefully about where it fits into the risk profiling. But the idea that maybe a very low corneal hysteresis comes as an additional risk factor, I think it's going to be a powerful one, and we've got to look carefully at that.
Great, thank you. Yeah.
I would say remember the graph, remember the plot with IOP on the y-axis and hysteresis on the x-axis, that it's the combination, not in isolation. And hysteresis should never be thought of as a constant parameter like CCT and curvature, that it's a dynamic parameter that changes with IOP and tells you about the damping ability of the eye. So if you have low damping ability with normal IOP, that's a giant red flag, which was demonstrated in that beautiful plot that was shown. So think of IOPcc and hysteresis together. None of them, neither one in isolation.
Great points, and I think we can't disagree with the value of more data. I'm going to say that Philippe Medeiros published some of this work 7-8 years ago, and the body of evidence with hysteresis is continuing to grow. We saw work from Gus Gazzard and others as well. And Dave, I know you have a bibliography of studies that give us certainly a good leverage point to help understand the value. For me, really, it's become a standard within my practice to do it. I still hang on to Goldman just because of reasons we mentioned, but I always like to have hysteresis and IOPcc measured at the time of diagnosis, and again also in follow-up as well. Hopefully, we've shared with you that there is certainly some evidence that hysteresis is a fairly important risk factor in glaucoma progression, and stratifying patients is low risk or high risk for progression. Looking at IOPcc appears to be more clinically relevant. Cynthia has nicely elucidated that point using some good examples with refractive surgery patients as well. And Gus nicely showed how looking at incorporating hysteresis may perhaps make us more aggressive for certain patients rather than relying on progression analysis, which can take some time on OCT or visual field. So a lot to chew on. I think that is very few people in the world would argue that CCT is not important. I think that that's become a norm in any presentation you see out there that presents a glaucoma case. If CCT is not on that slide, the professor is going to say, hold on here, what's the CCT, right? That's a norm. And I hope the day will come, maybe it should come now, that really what we should have is not just CCT, but we should have hysteresis on that slide when that glaucoma case is being presented. And we should have IOPcc presented on that slide to give us the true corneal compensated and adjusted IOP. It's 2021, guys. I mean, we're not back decades ago where we're only looking at IOP and only looking at Goldman. So I hope that this webinar has given us some provocative thinking to consider this. Nothing is perfect. More data is required. Aura provides value. Aura also adds some questions that we don't have answers for, as you've heard today as well. So it's incumbent on us to continue to evaluate, employ, and not to choose one tool or one measurement or one device when we basically make decisions. We need to look at the entire case, and of course, history is important, age is important, life expectancy is important. All these are different important measurements, including quality of life, before we jump on and do something. There's never a simple answer that we get. This is not refractive surgery, with all due respect. And so I want to hand it back to Dave to finish off, maybe with another poll question. Hopefully we've shared with you some more information about hysteresis and given you perhaps some ideas to contemplate as you consider managing glaucoma patients. And I want to thank very much Gus and Cynthia for an enlightening conversation, two heavyweights when it comes to these areas, whether it comes to glaucoma management or biomedical engineering. I try to keep my mouth shut most of the time to learn from both of you, so thanks so much.
Thank you.
It's a pleasure.
Thanks, Ike. Thanks, Gus. Thanks, Cynthia. This has been a lot of fun. Appreciate you taking the time to join us. A couple more questions just came in. Somebody asked if teardrops were necessary prior to aura. No drops of any type are. Actually, we discourage it because that would actually cause some droplet splatter. Will this video be available afterwards? Yes, you'll receive a link. If you registered for the event, you'll receive a link to see the recording of the webinar. I'm going to launch the same two polls we took before you heard the discussions tonight. So the first poll question then again is, do you understand how to incorporate corneal hysteresis into glaucoma decision making? And let's see if we move the needle. And now we have it. It was about a 50-50 split before. Now it is 86% yes. So I think the education provided by Gus and Cynthia and Ike tonight was really useful, apparently, to our audience in understanding how to use corneal hysteresis in glaucoma decision making. So just a few closing comments. Thanks everybody for sticking with us a few minutes past our scheduled end time. Reichert Technologies, formerly American Optical back in the old days, been around for a long time, and we have a heritage in tonometry that goes back over 70 years. I believe Reichert's first tonometer was a Schiot's, believe it or not. But we are knee-deep in tonometry at Reichert. We own the TonoPen franchise. We have the Model 30 NUMA tonometer. We invented the non-contact tonometer. We even make Goldman tonometers. So nobody knows tonometry like Reichert knows tonometry. And all these products are developed and assembled in Buffalo, New York, here where I am, just a few hours south of Ike there in Toronto. The ORA G3, or the Ocular Response Analyzer G3, is currently the only device capable of measuring corneal hysteresis and IOPcc. We also have another junior model, if you will, called the 7CR that provides the IOPcc only if you're hesitant to dabble in corneal hysteresis. We have a lot of international folks on this webinar tonight. Go to our website, look up who your distributor is, or get in touch with us directly if you would like to do a demonstration of the instrument. We can even do a virtual demonstration just so you can get an appreciation for how big the thing is, how you use it, and what the patient does, what the patient looks at, all that sort of stuff. So please feel free to reach out to us if you're interested in learning more about the instrument. Please take our post-webinar survey. You'll get an email asking you to do that. And if you're interested in another webinar on April 8th, we're going to talk about a device called the CATS Tonometer Prism. This is available in the USA right now, not internationally. It's a replacement Goldman Prism invented by Sean McCafferty, shown in the picture down below. And we'll also have Nathan Radcliffe and Paul Karpecki joining Dr. McCafferty to talk about that exciting device. So I want to thank everybody for taking time to join us today. Thank our moderator and our panelists for being here, and look forward to seeing all of you, hopefully in person, later this year. Until then, be safe, be well, and we'll see you. Thanks, everybody.
Peace.
Thanks very
Thanks,
much.
everybody. Thank you.